Next, I'm going to invite up Dr. Bassam Sonbol. You just heard his name. Dr. Sonbol is a medical oncologist from Mayo Clinic, Phoenix. He's going to give a presentation on NETS 101, the NET terms and concepts you need to know, and fun fact about him. If you'd like to know a fun fact, he likes to run, and this means not just running after his two toddlers, he likes running marathons, and he competed in 2 marathons last year in 2024. How does he have time for this? Yes, that was his first 2, and he did well.
Thank you, Lisa. Thank you, everyone, for having me here. It's always a pleasure. See a lot of familiar faces. And I want to give a special thanks to Kimberly for sharing her story. I mean, this is amazing. I think it's very inspiring. So I'm one of the oncologists at Mayo Clinic, Arizona. I started in 2016, did my fellowship there since 2019, till 2019. And then since 2019 till now, I've been with them as a faculty doing GI cancers and focus on neuroendocrine tumors. We'll be talking kind of more like setting the stage for my fellow speakers afterwards as well, to kind of talk about some of the terms and concepts in neuroendocrine tumors. Let's see here. Yeah. So what are neuroendocrine tumors in general? And well, for the purpose of the talk, I just want to mention that we're trying to use the term neuroendocrine neoplasm to be kind of more inclusive of neuroendocrine carcinoma. I'll talk about that in a second. But for the purpose of this talk, I'm going to just use the term NET or neuroendocrine tumor. So neuroendocrine tumors, they are cancers at the end of the day, and they can arise from any part of the body. It can be bowels, or it could be lungs, it could be pancreas. Those are the most common sites. But they can really arise from literally any part of the body. And these tumors have very unique features. One of the features, they're called neuroendocrine because they have the endocrine capacity, which here, as it's telling you there, it's hormone-producing cells, so they can produce hormones. It's not a necessity. Not all of them have to produce hormones, but they have this ability to produce hormones. The term carcinoid is an old term. That's one of the terms just to kind of put there. It's still being used. I mean, initially when these cancers were described, they looked like cancer, so they called them carcinoid. But then later on, we learned that they are truly cancers. By cancer, I mean they can invade and they can metastasize. So they can leave the original place and go somewhere else. So that's another term. Metastatic, meaning left the original place, which is where, for example, pancreas, and has gone to liver, bones, and things like that. It's still being used in the official actually classification in lung. So lung, we have typical carcinoid, atypical carcinoid, and we'll talk about that in a second as well. So I mentioned how it's anywhere in the body, and this is a graph that's showing you kind of the more the dots you see there, the more that means it's higher in prevalence. So you can see GI and lung, so gastrointestinal tract and lung are the most common sites where you have these cancers arising. So when we say it's rare, so it's rare, that means it's rare in incidence. And there is a term called incidence and there is a term called prevalence. So incidence means the new cases diagnosed every year, and that's kind of, it is a rare cancer. It's estimated to be, I'll show you the data, it's about maybe 5 to 8% depending on the study you look at. 5 to 8 per 100,000. So you're talking about 50 or 80 people newly diagnosed in a million. But when we're talking about prevalence, meaning today in the United States, how many patients are alive and with the diagnosis of neuroendocrine tumors? I don't know if anyone wants to give a guess. No wrong answer here. Okay, a million is a big number. It's a little bit less than that. It's actually a quarter of a million. So you have 277,230 people. This is based on a study that just got published a few weeks ago in this journal called JAMA Oncology, and this is a very good journal. They looked at the data over the last 2 decades, and they estimated the incidence being 7 to 8 per 100,000 new cases. But then they estimated that there is 277,000 people living with these cancers in the US. So that's a lot of people. So yes, it is rare, but not so rare. Yeah. It's actually the second most prevalent cancer, meaning that if you look in the United States right now for the GI cancers, so you're talking pancreas, colon, stomach, and all of these cancers, it's actually just behind colon cancer. So it's even more common than the pancreatic adenocarcinoma and the others. What are the symptoms? So symptoms, you can think of it as more like symptoms that are arising from the tumor producing hormones. So you have hormone related symptoms, which are we have flushing, which is what we think about the carcinoid syndrome. So it's kind of mostly redness in the face and the upper chest. And flushing is not hot flashes. Flushing is more something objective, meaning someone across the room can tell you, oh, there's something, what's going on with your face or your chest. Hot flashes is more subjective, and hot flashes actually has other causes. And then we have wheezing. That's one of the things from from the hormones produced by the cancer itself. So that can be even in lung carcinoid, but it could be in other tumors as well, can cause wheezing. And this is very important, and I'm glad that you have someone to speak about that, because it's a very, very important topic, the carcinoid heart disease. These tumors, they can produce hormones, as we mentioned. One of the hormones is serotonin. And serotonin is one of the hormones normally in the body, but in neuroendocrine tumors, it's estimated to be amplified when they're functional. Estimated to be amplified 60 times actually higher. So the body has very hard time to get rid of it. So this effect of serotonin affects multiple organs, but mainly the right heart valves. So in the heart we have 4 different chapters, and we have right heart, left heart. So the right heart valves, we call them tricuspid, and pulmonary valves can be affected, and that's pretty significant. So it's very important to recognize that. That's mainly in functional neuroendocrine tumors usually. So that's why one of the tests that you hear your doctor doing sometimes is the HIA. We can talk about that in a second as well. So symptoms can be flushing, could be hormone related, but it could be from the tumor itself. So the tumor just sitting in the abdomen, for example, in the belly, can push and can cause pain in the abdomen, or it can cause diarrhea, which if you have a tumor in the pancreas, the pancreas normally is responsible for multiple things. One of them is digesting, producing enzymes that digest fat. So if you have a cancer in the pancreas, that cancer can affect the function of the pancreas, and that can lead to diarrhea because you're not digesting fat well. So a lot of the fat goes with the stool, and that can cause diarrhea. And then weight loss can happen as well as any other cancer. So one of the points here is flushing is not half flushes. You want to think about that always. So what makes NET unique? I mentioned how they're unique in many features. They have the feature of producing hormones, but also the thing is about, you hear NET, you hear well differentiated, you have probably all of these terms. So what are all of these terms? So whenever we talk to a pathologist, whenever we have a cancer, a neuroendocrine tumor or neuroendocrine tumor or carcinoma coming in for an opinion, we always have the pathologist look at the slides, and under the microscope, we ask the pathologist, how do these cells look like, these cancer cells? Do they look like the normal cells in the body? And that's what we call well-differentiated neuroendocrine tumors. Those are the well-behaved ones. So it's all, the differentiation is all about how the cells look like under the microscope. So we have well-differentiated, or if they look ugly, aggressive, small sometimes, or large, that's what we call poorly differentiated. So you have well-differentiated, poorly differentiated. Well-differentiated usually well-behaved, poorly differentiated are poorly behaved. The other thing that you also talk to the pathologist about is the Ki-67 stain, which is we literally tell them under the microscope, can you color do some coloring under the microscope and tell us how many of these cancer cells are aggressive. And they can give you a color that colors specifically the cancer cells that are aggressive, and they give you a score from 0 to 100%. So that's why you hear people saying, oh, my Ki7 is 23%, mine is 10%, and all of that. And that corresponds to grade 1, 2, and 3. So we have the grade 1, 2, and 3 is all based about the Ki67. So now you can imagine there's a spectrum. Starts with grade 1 and 2, end up with a 3. And then we have well-differentiated, poorly differentiated. So there are two different things, and they can overlap with each other. So this is the spectrum, as you can see. So we have well-differentiated, 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 poorly differentiated, and based on that, we have the Ki7. So grade 3 are known to be more aggressive, but not all of them are born similarly. You know, we have a grade 3 well-differentiated. There's still a villain, but a villain is different from another villain. Where is it? It makes a huge difference. So we can't just, and this is something actually new, because before 2016, the WHO classification for neuroendocrine tumors was anyone above 20% Ki7, we would call them neuroendocrine carcinoma, regardless whether the shapes are normal, like the normal cells in the body or not. But then we realized that, oh, no, actually there are patients who have grade 3, but under the microscope, they're still well differentiated. And I mentioned how the neuroendocrine tumors arising from the lung are a little bit more unique in terms of classification. They're still using the typical carcinoid, atypical carcinoma, and neuroendocrine carcinoma, but you can think of them not one-to-one correlation, but typical carcinoid, you can think of them more like a grade 1 net and lower grade 2. Atypical carcinoid, you can think of them more like a higher grade 2 and lower grade 3 well differentiated. And then you have the neuroendocrine carcinoma, which is kind of a cousin to the small cell lung cancer, which is associated with smoking. So my message here is grade is not the same as stage. Grade is about speed. Stage is about spread. And this is what I meant before. Neuroendocrine neoplasm, so NEN, equals net plus NEC. So, when we say net, is usually automatically we're saying well differentiated. Sometimes my nurse gets talk to the patient or gets a referral, and she tells me, it didn't make sense because they're saying it's a grade 2 neuroendocrine carcinoma, which doesn't make sense because neuroendocrine carcinoma, by definition, they're going to be high Ki7. It's going to be a grade 3. So as a patient, know your stage, but know your grade and your differentiation. I think it's important. So the neuroendocrine tumor cell, it has receptors. They're like, you can think of them like small antennas on the surface of the cancer cell. And these, we call them somatostatin receptors. And these are very important because we can actually, another name for them, we call them SSTR. But they're important because we can actually give the patient intravenous tracer or a contrast, goes all over the body, hook up to those cancer cells on these receptors, and then they would light up. And that's what, when you hear people saying, oh, I got a dotatate scan or something like that, which the dotatate is technically that drug that binds to the receptor. And the radio tracer, you hear people saying, well, gallium-68 or copper-64. These are just kind of the radio tracer that you're using to kind of show the light. So we use it for diagnosis, and we diagnose these cancers by imaging, so by the PET dotatate, and we do also sometimes do CT or MRI scans, depending on the situation. Now, the FDG PET is also used. FDG PET is a kind of intravenous contrast that's given, and the body takes up the contrast. The cells that are higher in metabolism, they're faster, they would light up. We usually use the PET FDG more in patients who have neuroendocrine carcinoma. So this picture is showing you, this is the back, this is the front, and this is a mass. This is the spleen, you can ignore it, that's normal. But this is the liver, and you can see here that this patient has multiple liver lesions that are lighting up here. The other way to diagnose, I mentioned how serotonin can be high, and that the body, to get rid of it, it changed it to 5-HIA, so we can check for that by urine or 24-hour urine, by blood or 24-hour urine collection. The other thing which is very, very important is biopsy. We can't diagnose this cancer without a biopsy or surgery under the microscope, and that's very important. We talked about the differentiation and the Ki-67. You hear the term AVID. AVID means lighten up. So when you're reading the report in the radiology report saying AVID lesions, that means that if you're doing a dotatate scan, those lesions are lighting up. So you have those receptors in there. So factors to consider on treating, my colleagues will talk about treating, but I just want to tell you that, treating this cancer, it's all about the grade. It's all about the positive or negative, receptors, and also whether the patient has any symptoms. There are patients who don't have any symptoms, or whether they have symptoms. You'll hear about the role of surgery from Dr. Singh, and also you'll hear about other therapies as well. And then we talked about how neuroendocrine tumors are unique. So I did some movie reference and now some book reference here. So we refer to them as zebras because they're unique, but not all of these zebras are the same. I couldn't find a better picture, so I just put this one. So all animals are equal, but some animals are more equal than others. So they are different in terms of the grade and differentiation. They're different from other cancers and different within the cancer itself. So they can produce hormones. We talked about that. They can affect the heart, and that's something significant. So my conclusions, neuroendocrine neoplasms are complex but manageable when we understand them, and we understand them now better than ever. And we still have a lot of things to learn about them. Know your grade and your receptor status. I put here SSTR, meaning the somatostatin receptor status. Also, one size does not fit all. So if you hear, oh, my friend has neuroendocrine tumor and got this therapy, why am I not on this therapy? Because each one of us is different with these cancers. And then lastly, you're not alone. There are 277,220, this was 230, but because I'm counting one of you. So 277,000 and 229 people like you. So, and we're all here for you, and thank you very much.
Thank you, Dr. Sonbol, for that excellent presentation.